Okay, hi everyone. Um, before we start with today's lecture, just a quick reminder, you do have your weekly quiz due tomorrow night. So don't forget to take your quiz, okay? All right, let's continue where we left off, talking about the different challenges that our immune system actually presents to modern medicine when it comes to being able to successfully do things like grafts and tissue transplantations. So last time we talked about how ABO blood type is probably one of the most important considerations in actually matching donor tissue with recipient tissue, because again, ABO blood types, the different ABO glycolipids and the Rh factor proteins that are on the surfaces of our red blood cells, if you're talking about the transfusion of blood, right, that is a tremendous amount of those antigens being introduced into a recipient or a patient's body, right? So those are antigens that can be very strongly detected and reacted against by an immune system. We say that these types of signals are strongly immunogenic. We left off last time with our discussion about solid tissues and how there are other challenges beyond just ABO blood types when you consider the transplantation of solid tissues. So this is the slide that we left off last time. Right? So very quickly, just to recap, we said that blood very much is a tissue, right? So just because it's blood, it doesn't mean it's tissue, right? Because definition of tissue is you have cells or a population of cells in some sort of a supporting matrix, right? So in this case, the blood, the plasma, the serum is the supporting matrix, even though it's liquid. Right? So we said that ABO mismatches between donor and recipient can lead to what we call hyperacute reactions. That means very rapid rejection of the donated tissue, the donated blood, by the recipient's immune system. We said that this follows, just like with allergies, a type 2 hypersensitivity scenario. Because what we're talking about is there are certain shapes, antigenic shapes, new epitopes on the surfaces of cells that are now being put into the patient, right, that the patient's immune system has never been trained to tolerate or be okay with, right? So as a result, you're going to have things like antibodies and B cells that produce these antibodies present that will react against these ABO and Rh antigens. Right? We said that in addition to ABO matching, when you're talking about solid tissue transplantations, right, you're going to deal with type 3 and type 4 hypersensitivities. Right? And these have to do with situations where there might be a relatively quick rejection of the solid tissue that's transplanted. That might take over a course of several days, for example. So we tend to refer to that as acute reaction. Or it might be rejection that doesn't happen right away, but might actually take months or even years to finally have the patient's body reject the transplanted tissue. And that we would call chronic reaction. In these cases, these follow a type 3 and a type 4 hypersensitivity. Right? And just as with allergies, right, type 3 involves the prolonged function of antibodies going to work and causing the detection of target cells by the immune system that eventually get targeted by the immune system and rejected. Type 4 does not involve antibodies. It involves things like T cells. Right? So just like with allergies. Right? But in this case, we're no longer talking about ABO mismatches. Right? We're talking about what if you matched the ABO blood type fine, right? Which these days, that's essentially a trivial thing to do, right? So they very rarely screw up on the ABO matching of donor and patient. But the other consideration with solid tissues is the MHC matching or HLA profile. All right, so that's what we're going to talk about today. Remember, when we've studied the function of these HLA proteins previously in the semester, we said that these HLA proteins make these MHC platforms on the surfaces of our cells, and our cells use those platforms to display small, short peptides that come from proteins from within the cell, right? And we said that our immune system depends upon the cells of our body to display or advertise what's going on inside of them, right, as the main way that immune cells that are passing by have a chance to kind of know, what's up with this cell, right? So remember, that combination of an MHC platform that is made up of HLA proteins and the peptide that it is presenting, right? That together is normally what your T cells of your body, whether helper cells or killer cells, will recognize. Right? Consider this. Again, just like with the analogy of the ID license or ID photo here, your HLA proteins themselves are like the actual driver's license here, right? So your HLA type is the Hawaii driver's license, right? That's what we have here in Hawaii. We're driving with that, right? Somebody else's HLA type might be the California driver's license, right? So if your body is used to or expecting to deal with the Hawaii driver's license being the thing that's presenting an example of a peptide. So for example, in both these cases, this is you, right? Totally normal peptide coming from a totally normal cell, right? Depending upon the ID type though that's used, right? Things can get kind of messy, right? So think about it as a guard, a security guard in a big, corporate office building, right? And so they kind of patrol around, and when people are walking around, people have their ID employee badges on them. So not only does the photo of the ID have to be self, right? So it's something that the security guards can determine, yes, this is you, right? But the ID itself, sort of more obviously, has to be the right ID card, right? So obviously, if it's an ID badge from somebody who works in a different company, right, maybe like a competitor's company, right, this security guard's not going to be as happy as he is in this photo here. Right? Again, because the ID card itself, the HLA proteins that make up these MHC platforms on the surface of your cells, is uniquely you, right? And your immune system has been trained to tolerate or recognize that that is HLA from your body, right? So if you have HLA that's coming from somebody else's body, right, that alone can pose a big problem. Remember, HLA proteins that make up these MHC platforms, I've already taught you, are some of the most highly polymorphic genes in the human genome. And we've learned that that's because variations in these HLA genes that make slight variations, different shaped HLA proteins, that means different MHC platforms, right, depending upon genetic background, might be better or worse at presenting particular small peptides on them. So you recall one of my favorite cartoons, right? I always go back to, I use any excuse to show this cartoon, is if the chicken represents like a protein inside of the cell that gets taken apart, processed by the cell, whether this is a totally normal protein that belongs in the cell or not, right? Maybe this is a protein that comes from a pathogen. The point is the cell takes it apart, and different peptide pieces of that protein, short, 10, 12, 15 amino acid parts of the protein, are presented on different MHC platforms made from different HLA proteins. Right? And depending upon the shape of those HLA proteins, maybe this one presents a particular peptide better than this one does, right? So we said that the more different pieces of the chicken that you can successfully present on the outside of the cell, the higher your success rate in actually having a T cell float by that can actually see that, right? So if this T cell only recognizes, its T cell receptor only recognizes the head of the chicken, right? It ignores the fact that there's a wing and a foot here, right? But what if you didn't have an MHC that could actually present the chicken head, right? This would be a missed opportunity for your immune system to see that something is present inside of the cell that you want your immune system to recognize, right? So as a result, these HLA genes are very polymorphic in our population. There's a lot of variety in genetic sequences, and that's good for us as a species, right? So that means that if you have a brand new pathogen that's introduced into the population, certain people, because of their particular set of polymorphisms in their HLA genes, their HLA shapes might be better for presenting chicken head, right? And therefore their immune systems have an easier time quickly identifying that the chicken is present, right? Whereas other people with different polymorphisms might not present the chicken head as well. Their immune systems are at a disadvantage in terms of being alerted quickly. Right? So because of that, and because these HLA proteins are so polymorphic, that causes a big problem, right? Because what are the chances that a random person who's donating tissue into your body, right? For example, a kidney coming from the donor, coming to the recipient, all of their kidney cells are covered in HLA proteins, but HLA proteins of their type, right? Their unique type compared to yours. So your immune system is not going to like that, because that is like seeing the California driver's license when you're fully expecting to see the Hawaii driver's license. Right? Normally, anti-HLA antibodies are very rare. Right? Because why? Think about this. The very fact that HLA proteins are a normal part of our bodies means, yeah, probably our immune systems are not very apt or very likely to select for B cells, randomly that respond, that make IGs that bind to HLA proteins, right? So right off the bat, the HLA signals probably are not something that your immune system is already busy trying to build up antibodies to. Consider also that somebody else's HLA type really has no business being inside of your body in the first place, right? So there's no reason why your immune system would have previously even occurred to it to select for antibodies against some other HLA type. In the natural course of how Mother Nature planned us to kind of live and what our immune system should expect to encounter, there are very rare circumstances when you'd actually encounter somebody else's tissues. So one of the examples is pregnancy. So let's look here. During the trauma of birth, right, you're going to have some mixing of baby's blood and mom's blood, and therefore mom's immune system will be exposed to potentially a different HLA type, because baby's HLA type is a mix of mom's HLA type and dad's HLA type. Right? So if you look down at the cartoon here, so mom and dad have different HLA types, again, based upon their ancestry, their family lines. So when they conceive a child, right, that child, his or her HLA type is going to be a mix of blue and pink, right? Because one copy of the HLA genes comes from dad, one copy of the HLA genes comes from mom, right? So during pregnancy, there's not going to be a mixing of baby's tissues and mom's tissues. But during the trauma of birth, right, as things like the placenta is separating from the endometrial lining, right, you're going to have a lot of blood vessels that are going to get torn. It's very messy, right? Inevitably, you're going to have mom's immune system being exposed to baby's HLA type. Right? So it may be that mom begins to produce antibodies against the paternal, against baby's HLA type, right? But that won't affect baby being somehow at risk, right, being born. Right? The other common situation is now getting into more of an unnatural situation, blood transfusions, right? Again, right, Mother Nature never intended or designed us to be able to exchange blood with each other, right? The fact that we do it as a way to save somebody's life is just something that we've come up with, right? That's medical technology, right? That's only been around for, what, maybe 100 years, something like that, maybe even less, right? Compared to the hundreds of millions of years that our immune system has been finely tweaked to be able to expect certain things and not expect other things. Right? So when you have a person who receives blood transfusions, you're not only receiving, red blood cells that have ABO blood type on them and Rh positive or negative, right? So hopefully that part already is sorted out before you receive the blood. But think about all the other cells that might be part of that as well, right? You're going to have other cells that have HLA proteins on them. And so as a result, right, that exposure through blood transfusion can lead to the recipient, the blood transfusion recipient, building up now an immune memory against particular HLA types. So that really only comes a problem if this is a patient who needs repeated transfusions, right? And they get repeatedly transfused with blood that has similar HLA types, and over time, right, they might develop some sort of immune memory against it. Therefore, the presence of existing anti-HLA antibodies in your body, right, is typically not a concern when it comes to tissue transplantation. The problem comes, though, if you go ahead and transplant solid tissue into the body from somebody else, and now your immune system, right, is being forced to somehow live with the fact that there's this tissue in the body that has a different HLA type, that's when you get rejection. Right? So this rejection might be very quick because it might involve direct immune cell interactions targeting the healthy donated tissues, or it might be more drawn out. So let's look at these two examples here. So direct, or what we call acute type 4 rejection, happens when, let's say, you've transplanted something like a kidney, right? And in that kidney are going to be, all kinds of cells, not just the kidney cells that you're intending to transplant, but remember the kidney tissue is filled with blood vessels, of course, and at the time that you're transplanting it over, there's going to be many other cells from the donor that are kind of like hitching a ride, right, on that kidney and being transplanted into the patient. Among those probably are immune cells, like dendritic cells. So here we have, in this first illustration on the left, a dendritic cell that came from the donor, right, that kind of hitched a ride in the donated, tissue, right? And so this dendritic cell, as a result, its HLA type, in other words, the MHC platforms that it uses on its surface to present things, to show other immune cells, are the donor's HLA type, right? Meanwhile, this dendritic cell, now that it's in the new body, hey, right, it wants to go to work, right? So it goes around and it maybe gets into the lymph nodes and it starts meeting all these T cells, right? T cells that were made by the patient, the recipient, right? So these T cells in the patient, they've been trained to tolerate and recognize, right, the patient's own self MHCs or self HLA type. Right? So when they encounter this donor's dendritic cell, a lot of them will just improperly go ahead and start binding to the MHC just because the MHC is a different shape, and therefore there's a very good chance you would have T cell receptors, right, that recognize that shape, because again, they were never told not to, right? They were never have been screened out as part of negative T cell training. If this happens, you might have cytotoxic T cells from the recipient's immune system immediately start attacking the not only the donor's dendritic cell, but also they will activate and start attacking the other kidney cells that are part of this donated organ, because all those other kidney cells as well have the donor's MHC type on it. Right? Likewise, you might have helper T cells that activate against the donor's MHC, right? And this just makes it worse, because now the helper cells are going to go out and start recruiting other immune cells to attack the donated kidney, right? So that's pretty fast. Indirect allo recognition is much slower, Because in this case, what we're saying is, what if in reality, okay, you don't have direct allo recognition, right? So good, you lucked out, right? It seems like the patient's body is tolerating, right, this different HLA type. But eventually, over time, things start going bad. Why? Because here is that donor's dendritic cell again. Maybe eventually it just gets worn out, right? So it's time for it to be recycled. So here it is, right? And it gets recycled by something like another dendritic cell that's picking up bits and pieces of random little scraps of things as the recipient's dendritic cell is just doing its job. So it picks up the MHC that comes from the donor and it processes it. And so the yellow dot then just represents peptides that come from the donor's MHC. The recipient's dendritic cell, does its normal job of loading up those little yellow dots on MHC2, right? And now it's displaying the yellow dot on MHC2. And so a recipient's CD4 cell comes along, right? So this is a CD4 cell that's properly trained to happily bind to MHC2 of the recipient, right, with the proper kind of affinity, right, not too tight. But unfortunately, it sees that this yellow dot is something different, right, because this CD4 that was made in the thymus as part of VDJ recombination, right, its T cell receptor randomly is the right shape to bind this yellow dot, right? Even though under normal natural circumstances, this particular CD4 cell would have never encountered this yellow dot, right? And it just would have ended up going on its way, and then after a few weeks, just being recycled, right? But in this case, right, it does see the yellow dot because it comes from the donated tissue, right? So over time, right, this now will start an immune response. So let's take another closer look at these two. So acute type 4 rejection via direct T cell activation, right, again, has to do with the fact that the patient's very unlikely to have any antibodies pre-existing in their body that recognize the donor's tissue, right? Because we're not talking about a type 1 allergy response that would involve IgEs, or even a type 2 that would involve IgGs, right? Because both of those situations imply that at some point in the past, you were exposed to these things and your immune system made a mistake, right? And that's why now you have these IgEs or IgGs, right? If you're getting somebody else's kidney, I mean, why would you in the past have ever been exposed to that kidney before, right? So it's not going to be a type 1 or type 2. It's going to be more of a type 4 rejection involving T cells. So here, once again, here's the kidney that was transplanted into the patient. In that kidney, hitching a ride were various other, not necessarily kidney cells, maybe like dendritic cells that also come from the donor, right? So once they're attached, like the surgeons attach all the plumbing to the kidney, right? And then these dendritic cells then will migrate out into the new body, right? And they make their way into something like secondary lymphoid tissue, like a lymph node, or in this case, they're using the example of a spleen, right? Spleen is another example of secondary lymphoid tissue. And these donor dendritic cells, right, are going to work, right? So they're all happy. They're like, hey, I don't know what just happened there for the last few hours because that was weird, but now we're back in the body again, right? And so they go to secondary lymphoid tissue and they encounter something like a naive T cell, right? And this naive T cell freaks out, right? Because this is the wrong MHC type on these dendritic cells. That means there's a really good chance that this T cell will just activate, right? Even though the actual antigen is being shown by these dendritic cells, there's nothing wrong with them, right? But the T cell doesn't care because the shape of the MHC is wrong. And so that's enough for its T cell receptor to activate. So these T cells then proliferate, they go through the blood, and guess what they find, right? They make their way into that donated kidney and they're like, right, this is the source of all those weird signals, right? What is this? Whatever it is, we don't like it because it's foreign, right? It's bad. We have to get rid of it. And so then the T cells begin to attack the kidney tissues, all of the cells of the kidney that came from the donor. And this happens over the course of several days, right? So it's not hyperacute. It's not the super strong ABO blood type mismatch response that the immune system has, right? That might actually destroy something like this kidney within just a few hours, right? This is more drawn out. This involves T cell selection, T cell activation. This would take a few days. But I mean, look, a few days is still really fast, right? I mean, that's really sad if after all that waiting for a donor organ, right, and all the preparation and all the surgery, hours of surgery, right, just a few days later, the kidney is destroyed by the immune system. Right. Chronic or type 3 rejection, right, involves more indirect T cell activation. So in this case, maybe you don't have acute rejection, right? Maybe, for example, the HLA types were close enough that you don't have T cells in the donor, I mean, in the recipient, that really freak out against the new kidney, right? And so maybe, everything looks great, right? The patient recovers weeks, a few months later, they're still okay, right? But over time, though, things begin to get problematic. Why? Because while the tissue, continues to exist and function, like the kidney that was transplanted keeps functioning in the body, right? The body's own dendritic cells are picking up bits and pieces of things like MHC proteins from kidney cells that are being recycled, right, and presenting those to helper T cells. Gradually, over time, the patient will start building up selection of helper T cells that do recognize this foreign MHC as being a problem, right? And at a certain point, it'll reach a level where those T cells are then working with B cells. Those B cells are making antibodies, right? Gradually. So this is a cross section here. This cartoon is a cross section of one of the blood vessels inside of the donated kidney, right? And what happens is you start building up antibodies, right, that start binding to the wrong MHC type that's present inside the kidney's blood cells. And that starts recruiting different immune cells, and they go to work. And so over time, you gradually damage the kidney tissue, right? It's not a very strong response, but if it now starts being drawn out over several months or even years, eventually, right, the blood vessels inside of the kidney are just too damaged from repeatedly being sort of, targeted by these antibodies. So I should point out to you that you might think, well, certainly these days when we have solid tissue transplantations like kidney transplants, you must think, well, we've gotten much better at this, right? Actually, yes and no. We've gotten much better because we have a much deeper understanding now of how to kind of prepare the immune system and how to counteract their immune system to try to make tolerance of donated tissue a lot better and more successful. But the truth is, you might be surprised that even today, successful organ transplants, right, don't really last for the remainder of the person's natural life. I think I saw a study where at this point, even successful solid tissue transplants, once you get out to the 10-year mark or the 12-year mark following transplantation, about 40% of all successful organ transplants still fail, and the organ is rejected, after roughly the 10-year mark or so, right? And that's because of these chronic type 3 rejections that are long and drawn out. And this makes you think about the fact, because in the end of the day, you cannot fool Mother Nature, right? Mother Nature designed us over hundreds of millions of years to be really good at detecting things that don't belong in our body and getting rid of it. So just because we think modern science, modern medicine, we're so clever, we can transplant solid tissues now, right? What you're really trying to do is you're going against what Mother Nature intended us to do. Mother Nature never intended us to take a kidney from one person and put it into the other, right? So as a result, our immune system is just not geared up to be okay with that, right? So that's a big challenge that's faced with these types of procedures. So even the procedure itself, the transplantation, has many opportunities for the immune system to kind of freak out and start an immune response. So when you consider that, let's say there's a scenario here where an organ becomes available for donation. So in this case, from an accident, a traffic accident. So importantly, this is a totally normal, otherwise healthy individual, normal, healthy kidney. It becomes available now, right? So the kidney is then removed from the body. And from that moment on, right, from the moment of death and the kidney is put into special transportation, right, already the tissue of the kidney is suffering. Right? There's going to be tissue damage. The cells of the kidney are freaking out. They're releasing things like inflammatory cytokines, right? The patient waiting at the transplant center and gets notified that, they have a kidney on the way in preparation for undergoing surgery. Of course, they're given all types of drugs as well. And many of these drugs, unfortunately, also induce inflammatory responses. So the combination of the tissue of the kidney itself becoming inflamed, right, as well as the whole immune system of the patient during pre-op, getting ready for operation, already starting to have inflammatory types responses. What does this do? It raises already the sensitivity of the immune system to react against the donated tissue. Right. So some strategies then that can be used to encourage successful transplantation. Number one, not surprisingly, right, is matching the HLA profile as closely as possible between donor and recipient. Right? Now, obviously, I don't mention the ABO blood type in here, but that's a given, right? It's a given that you have to match the ABO blood type first, right? But because we're talking about solid tissue now we also have to worry about matching the HLA type. That is why, I think you're all aware of this, right? Most frequently, donors are found within the patient's own family. I mean, of course, there are emotional reasons for this, because obviously a sibling is somebody who is emotionally invested, right? And it has close ties to the patient, and therefore is more likely that it's a family member who donates this kidney. But there's also good practical reasons too, right? Because the HLA type, genetically, they're very closely related. So the HLA types are not going to be very different from each other. So identical twins, for example, are an ideal situation for donating tissues because they have the exact same HLA type. Right? Number two, anti-inflammatory medications. Right? So as part of not only immediately following the operation, but also during recovery, the patient is given a lot of strong anti-inflammatory drugs. So different steroids, such as prednisone. What that does is that keeps the inflammatory responses down in the body's tissues. So you don't get a lot of interleukins being released. Hey, hopefully, again, you've learned that inflammation is one of the key things that our immune system looks for as evidence, right, that it should be waking up and looking for some sort of threat, right? Some sort of threat that's causing the inflammation, right? So if you give a person a lot of anti-inflammatory drugs, you're hoping to keep the activation of the immune system down. And you can directly, number three, give immunosuppressive medications, right? Drugs that are designed or selected to directly inhibit the activity of certain effector cells from participating in an immune response. Many of these target white blood cells in order to inhibit their activity. Some of these drugs are immunoglobulin based, or they're based on synthetic peptides. What's interesting is that several different types of drugs actually come from various microbes. Okay. So let's take a look at some of these examples to kind of round out our discussion today. So here's an example of an antibody, alemtuzumab, that's used to help treat patients during recovery when they've received an organ transplant, right? So this is an IgG, so it's a purified high-dose IgG, and what it does is it binds to the CD52 surface protein on white blood cells. Right? So remember CD52 when we talked about the differentiation of blood cells. This is a marker for things like white blood cells, right? So this IgG is designed to bind to CD52, and what does it do? Just like what it's supposed to do. When antibody coats the surfaces of a target cell, it recruits things like complement protein, right? So you end up labeling a lot of the white blood cells. You opsonize them with complement protein, and as a result, the immune system then attacks the white blood cells, right? So you lower the patient's white blood cell level, right, to try to discourage white blood cells from freaking out and being selected and activating the immune system. Here's another example of not an antibody, but just a small peptide, this belatacept over here. It's a chimeric peptide. It's very clever. If you look at this cartoon on the right, this should be familiar to you. Here is an antigen presenting cell on the bottom over here, right? It's presenting something like a peptide on MHC protein. And here you have a naive T cell, right? Naive T cell that has a T cell receptor that recognizes this particular peptide on it, right? But it needs what in order to activate? It needs that second signal that comes from the B7 CD28, right? This is the professional antigen presenting cell on the bottom. So this is the salesperson, right? She's wearing her B7 badge so that when you're in the store, right, and she comes up and talks to you about, can I tell you about this product, whatever, you actually realize, oh, okay, I'll listen to you, right? Because you're not just some random person who walked up to me. You're actually a trustworthy source of information here, right? So the belatacept protein, it's a peptide. It's made of two parts. In the cartoon here, they just show it as being this pink part and this yellow part. But the idea is the pink part's the right shape to bind to B7, okay? And this yellow part, right, will not bind to CD28. So as a result, the belatacept gets in the middle of the B7 and prevents it from binding to CD28 so that T cells in the patient do not activate against the foreign transplanted tissue. Right? Here are some examples of immunosuppressive drugs that come from microbes. So the first one is this cyclosporin. So it's isolated from this particular fungus here. Right, so here's a picture of the fungus here. So speaking of driver's licenses, you thought your driver's license photo was bad. Look at his, right? That's pretty sad. All right, but anyhow, I'm sure his mom thinks he's cute. Okay, so this drug, what it does is it's a small drug, right? It's a small compound, so we're not talking about a protein or peptide. It actually binds to cellular components inside of the T cell and blocks the T cell receptor signals from reaching the nucleus of the T cell. So therefore, even if the T cell is binding to things like foreign MHC from the donated kidney, right, these T cells won't activate. Tacrolimus or FK506 is another example. This one is isolated from soil bacteria, right? And again, it works by blocking the T cell receptor signals from reaching the nucleus of the T cell, so the T cell never activates. Third example is rapamycin. So rapamycin also comes from soil bacteria. Right? The way rapamycin works is it prevents IL-2 receptor from activating. Remember, when a naive T cell is first activated, right, one of the first signals that it needs to start proliferating and really sort of fully differentiating and activating is interleukin-2. So the T cell itself, as it activates, it begins to make IL-2, and so it can actually signal itself in an autocrine fashion, right? And remember, we also learned that helper T cells can help cytotoxic T cells activate by giving the cytotoxic T cell IL-2. So IL-2 is one of the most important signals in order to get a T cell to properly activate. And as a result, if you can somehow block the receptor on its surface that is meant to bind IL-2, you can very effectively prevent T cells from activating. I like this example because the name rapamycin, do you know where it comes from? So you guys know what this is, right? One of these moai from Easter Island, right? So Easter Island was where this particular soil bacteria was first isolated from, where they get this particular drug from. And of course, in Polynesian, the name of Easter Island is what? It's Rapa Nui, right? So it's kind of nice. I think that works really well and reminds us that here is some recognition right here in the Pacific of some of these very important cultural locations in Polynesian culture. All right, here's a question for you. Right? Why would these microbes like fungus and soil bacteria, what business do they have making certain compounds that can interfere with T cells, right? I mean, after all, bacteria, fungus, they don't have T cells, right? So what's up with that? But consider this, right? These can be considered as pathogens, pathogens that potentially can infect other, animals, right, as potential hosts. And so evolutionarily, they have evolved to produce certain types of compounds that can interfere with host immune systems. So for example, compounds that can interfere with things like T cell signaling. Right? So I think it's wonderful that modern medicine can take these compounds and actually use them, right? Use them for their immunosuppressive qualities as a way of treating patients who are recovering from solid tissue transplantation, right? But I do want you to think about this, that as I said, even in the best case scenario, right, a patient who is on these highly immunosuppressive drugs, right, can maybe expect to have their donated kidney last maybe like a decade or so, right, before eventually Mother Nature wins out, right? The very strength and integrity of our immune system and how powerful it is ends up being the thing, right, that we cannot beat, and it will eventually reject the foreign tissue. Right? Consider also that patients who are on these types of medications so that they tolerate having a foreign kidney in their body, hopefully for years, right? Their immune systems are highly suppressed now, right? So it's not like they can really lead a totally normal existence or life compared to what they did in the past, right? Because they're always going to have a compromised immune system, so they have to be more careful and diligent about lifestyle choices, foods they eat, exposures that they encounter, right, as part of their modified daily life routine. Okay, all right, let's go ahead and stop there.